My name is Dr. Tom Nillis. I'm a neurosurgery resident here at the Nebraska Medical Center, and I'm going to talk to you today about posterior strokes. Strokes, in a nutshell, is when there's disruption in blood flow to the brain. It can either be hemorrhagic or ischemic. Ischemic strokes can be further broken down into embolic, which is when a particle gets pumped into the brain's circulation and prevents blood flow. Thrombotic, when a blood vessel within the brain clots off, preventing blood flow. Or global, and that is when the heart cannot pump blood into the brain at an adequate rate in order to supply the brain with oxygen. The brain is supplied from 2 internal carotid arteries and 2 vertebral arteries. The 2 internal carotid arteries enter the brain and form the middle and anterior cerebral artery, whereas the 2 vertebral arteries, which run in your cervical spine, enter the brain, enter the cranium, and then form the basilar artery, and then which eventually gives rise to the 2 posterior cerebral arteries. There are many perforators off of the vertebral and basilar arteries which supply the brainstem as well as the cerebellum. We can further characterize strokes by saying if they're in the anterior versus posterior circulation. The anterior circulation being any stroke affecting the internal carotid artery, middle cerebral artery, or the anterior cerebral artery. A posterior circulation stroke is therefore any stroke involving the vertebral artery, basilar artery, posterior cerebral artery, or any of their branches. It's important to know the difference between these two because these strokes manifest in very different ways. The anterior circulation supplies the frontal, parietal, most of the temporal, as well as part of the deep nuclei of the brain. And these areas are important for higher motor functioning, such as movement, sensation, as well as high cognitive function. There are also many parts of language that are involved in this area. The different functions that are supplied from these circulations give rise to different stroke symptoms if blood flow is cut off. Anterior strokes commonly manifest with weakness, numbness, language impairments, or cognitive issues, whereas posterior strokes manifest with subtle symptoms such as dizziness, difficulty walking, or difficulty with coordinated movements, sometimes double vision or visual field deficits. It can also manifest with nausea, vomiting, and difficulty swallowing, or even difficulty speaking. Anytime you approach a patient that you suspect has a stroke in the field, you need to establish time course. What happened, when it happened, and the progression over time. Especially knowing what time something started is important because that will dictate what treatments we can do within the hospital. Next, getting a good medical and social history is important because this can give us clues to stroke risk factors and things that we can treat in an outpatient setting to help prevent future strokes. Getting the home medications is essential, especially the antiplatelet and anticoagulation medications, because this will have implications to what treatments we can do and how soon we can give treatments. One thing that's specific to EMS is making sure we place a right-sided IV. This is important because it will help us get access early and also not interfere with future treatments or interventions we may do in the hospital setting. And finally, getting a good neurologic exam. When assessing stroke patients, BFAST is a common mnemonic, and it is a very helpful one. But when we're assessing a patient in the field, getting a full neurologic exam is a little bit more beneficial to us. We can still use the BFAST mnemonic, but we would like to expand upon it a little bit, and I will do so here. But first, I'm going to run through the full neurologic exam. So whenever we approach a patient, we want to look at their level of consciousness. Can they talk to us? Are they interactive? Do they understand what's happening? For patients with decreased levels of consciousness, the Glossal Coma Scale is a great tool to use. Next, we want to assess their mental status, if they're alert and oriented. Like I said, do they know who they are, where they are, and what's happening? After we do a basic cranial nerve exam, we can move on to assessing motor function. Motor function primarily is looking at the strength. Can the patient move any of the limbs? Can they move the limbs anti-gravity? And if the patient can move them anti-gravity, you should assess for drift. This will help detect subtle weakness. Also, it's important to look at the muscle tone. Is the limb flaccid? Is it spastic? Or is it normal? After we test motor function, we can test sensory function. This consists of sensation, testing for sensation to light touch on the face and arms and legs. And if they do have sensation, test for extinction, which is simultaneous stimuli to both sides. A patient with sensory extinction will not feel one side, but will feel the other. A more profound area would be something called neglect, where a patient will not feel anything on one side and will actually ignore one side of their body. Next, we would test gait. We'd only do this if we deem that the patient is safe and they can ambulate safely, or they have enough support where if they were to fall, someone would catch them. We would look for asymmetry and fluency in their walking. In tandem with gait is coordination. We can test this with a finger-to-nose test or a heel-to-shin test. In summary, we can still use the B-FAST mnemonic and get that full neurologic exam if we just add a little bit. B for balance and coordination. Here we would look for the finger-to-nose test, the heel-to-shin test, and assessing for gait. E for eyes. We want to check the pupils. We want to check the visual fields. Check the extraocular movements, assessing for nystagmus. F for face, looking for symmetry, and to remember if there is asymmetry, to see if it's asymmetric on the upper and lower face or just the lower face, and also testing for sensation. A for arm, I also added leg here. Here we would test for strength, sensation, and tone. And remember, when we test for strength, to also assess for drift, and when we're testing for sensation, to look for neglect and extinction. S for speech. This one's I added on a little extra because we want to assess for dysarthria. And finally, T for time. And remember, time equals brain. So the faster we get a diagnosis, the faster they get to the hospital, the faster they get treatment, the more brain we can save when we're treating stroke patients. Hi, I'm Tom. I'm with EMS. What made you call us today?
Well, I was at work and having a normal day, and all of a sudden I just got so nauseous. I felt like I had to puke so bad and extremely dizzy. And with that, my vision has started to get fuzzy. It's kind of blurry at the edges. It's like I'm kind of tunnel vision, and I'm just so nauseous and dizzy.
Okay. When did this dizziness and nausea really start?
Just now. It just happened. I mean, it's been, 20 minutes, 30 minutes.
Okay. And just like really intense nausea, dizziness, and the blurry vision all kind of started pretty suddenly, it sounds like. Or
yeah.
Is that true?
That is true. It just, I was going about my day, doing my work, and just hit me out of nowhere, and it is overwhelming.
Has it changed at all since it started, or is it still just kind of maximal intensity?
Yeah, no change, just pretty intense, and only been a bit here.
Okay, well, like I said, I'm with EMS. I'm going to evaluate you to see, what's going on. I think it does sound like a neurologic problem, so I'm going to do a full neural exam if that's okay. First, a couple silly questions. Can you tell me your name?
Edgar Thomas Blossom.
Okay. Where are we right now?
At my work.
Okay. And what month is it right now?
It is January.
Okay, good. Next, I'm going to have you stand up. Do you feel comfortable doing that?
Yep.
Okay. All right. You can sit back down. It looks like you're leaning a little bit. Do you think you are?
No, I didn't notice that, but
it's okay. Next, I'm going to have you take your heel and run it up and down your shin like this.
Okay.
Yeah. Can you do it with the other leg now? Good. All right. Take your pointer finger on your right hand. Now touch my finger. Now touch your nose. Now touch my finger. Now touch your nose. Okay. Can we try with the other hand? Touch my finger. Now touch your nose. Touch my finger. Now touch your nose. Okay? You can relax. Next, try to follow my fingers with just your eyes. Okay. Look right here. Do you see how many fingers I'm holding up?
yeah,
How many?
2,
All right. How many fingers am I holding up?
1,
Okay. How many fingers?
2,
How many fingers?
3.
Okay. Next, can you give me a big smile? Can you wrinkle your forehead? Good. I'm going to touch your face in a couple spaces. Let me know if it feels the same on both sides. Feels the same?
Yeah.
Okay. Close your eyes real quick. What side am I touching?
Left. Right. Both.
Good. You can open up your eyes again. Next, can you take this leg and lift it straight in the air? Good. And this one, lift it straight in the air. Good. Can you squeeze my hands real tight? Good. Pull me towards you. Push me away. Good. Lift your arms up flat like this. Now close your eyes. Alright, you can relax. I want you to keep your eyes closed. I'm going to touch your arms and your legs in a couple spots. Let me know what side I'm touching.
Left. Right. Both. Both. Right. Left.
Okay. Does it feel the same on both sides?
Yeah.
Next, I want you to repeat after me. Today is a sunny day in Omaha.
Today is a sunny day in Omaha.
Perfect. Repeat. No ifs, ands, or buts.
No ifs, ands, or buts.
Okay. And what is this?
A watch.
And what does a watch do?
Tells us what time it is.
Perfect. Next, I'd like to go through an example of dysarthria versus aphasia. Dysarthria being a problem with the motor function of speech, and aphasia being a problem with the language comprehension part. Dysarthria is oftentimes described as garbled or slurred speech. And an example is right here. Can you tell me your name, sir?
My name is Edward Blossom.
And where are we right now?
At my place of work.
There you can see that he is slurring his speech and he almost has decreased tongue mobility, and that can be a contributing factor to dysarthria. Aphasia, on the other hand, is a problem more centrally with language, and it can manifest as something like word salad, where people will believe they are speaking in coherent sentences, but really they are just throwing together a string of words. There's another form of aphasia where a patient has a decreased ability to produce speech, which manifests similar to dysarthria, but the patient will be able to speak clearly, but just have a paucity of words that they can produce. The second aspect is a little bit above and beyond this topic, but the primary aphasia, or receptive aphasia, will be demonstrated here. Can you tell me your name, sir?
I'm here, chair, with all of us, together project.
And what are we doing right now?
Light, sees, cleaning, together.
As you see, the patient believes that he's speaking in a full, coherent sentence and answering me appropriately, but he's truly not, as you can hear just by the word salad he produces. When assessing the eyes, you want to assess the extraocular movements, and that is done by having the patient follow your fingers, both laterally, superiorly, and inferiorly. One thing that's important is to hold the gaze at each point for a moment or two, and then watch the eyes. A nystagmus is when there's fluttering between a midline point and the point that they're trying to look at. It's important to distinguish this because this can indicate a small weakness in those muscles or in the nerve transmission there, and that can also indicate a stroke. When assessing sensory function, it's important to assess for neglect and extinction. Neglect is when a patient neglects one side of their body. They may have the motor capability to move that side of the body, but when asked to perform a task, they will not perform it on that side of the body. It might present like this. Can you lift up both arms for me, sir?
Yes.
Are you lifting both arms right now?
Yes.
As you see, the patient believes that he's moving both arms, when in fact he's only moving one side. patient with neglect may be able to move that right side, but won't be able to follow commands. Also, it is important to assess for extinction. Extinction is when two stimulus are applied on one to each side of the body at the same time. The patient will only perceive one of the stimulus, despite being able to feel both sides. It might look like this. Do you feel me touching your leg?
Yes.
Do you feel me touching your leg now?
Yes.
What leg am I touching?
Left.
As you see, the patient could feel on both sides and expressed that previously, but when asked, when feeling both stimuli, he only felt it on one side.